unable to walk or weight bear on the affected side since the injury. Patient was on assisted ambulation even before trauma and now is bedridden. Patient was diagnosed with osteogenesis imperfecta in the childhood. Patient gives history of multiple fractures since childhood till the age of 14 years. Patient had undergone management of those fractures by indigenous sprinting, after which he developed deformities. He was explained about his conditions at 14 years of age. Patient had classical features of osteogenesis imperfecta like blue sclera, sawtooth, and difficulty of hearing. Patient had tenderness over the proximal femur. Silence classification was used to grade the osteogenesis imperfecta. The following investigations were taken in which the transverse fracture of the femoral shaft along with overriding and comminution were seen. A CT scan was also taken for the right femur. Vinquist classification was done for femoral shaft fractures, and this comes under type 3 where 50 to 100% of the circumference of the two major fragments is comminuted. The serum alkaline phosphatase was elevated. We diagnosed it to be a femoral shaft fracture of the type 3 Vinquist classification with type 1B silence classification. We had ORIF with plating as an option, but since it's a load-bearing device and has higher chance of periprosthetic fracture, we went for intramedullary nailing, which is a load-sharing device and ideal for pathological fracture. The external fixators were also an option, but the patient was not willing. This is a literature supporting the use of intramedullary rodding done for osteogenesis imperfecta, which had better results with long-term follow-up on 10 years with minimal migration of the rod and showed better results in ambulation. But shortening was a complication. The plan was to do a proximal and distal osteotomy near the fracture site to correct the deformity with intramedullary interlocking nailing of the right femur. The intramedullary nailing was done. We had nails of all sizes available and used a radiographic ruler to measure the size and length and diameter of the nails. These are the post-op radio X-rays. The post-operatively, the patient was satisfied with the outcome and he wanted to correct his other deformities as well to achieve self-ambulation. These are the deformities of the patient, other deformities of the patient. These are the X-rays showing the deformities in the other limbs. The left tibia had a procavatum deformity of 410 degrees. An oblique plane deformity of 45 degrees was noted over the left femur. Right tibia had a procavatum deformity of 47 degrees. This is the X-ray showing the procavatum deformity along with the tibiofibular synostosis of the left tibia. Planning was done for the deformity correction to determine the number of osteotomies and angle of osteotomy to be done. Patient was planned for deformity correction with osteotomy and Ilizarov fixation, but due to the functional difficulty of the ring fixation and long duration of treatment, patient was not willing for the treatment. So intramedullary nailing was done. Intramedullary nailing being a load-sharing device with early functional outcome and cosmetically accepted by the patient, this was done. Because the immobilization post-surgery was also reduced, the effects of osteogenesis imperfecta, in which bone resorption is common, was also negated by intramedullary nailing. For the procavatum deformity, we planned an intramedullary interlocking nail with tendo-Achilles lengthening, which is called the Sofiel's procedure. These are the intra pictures of the procedure. C-arm images. This is a 6-month post-op X-ray of the nailing done for the procavatum deformity. This is a left femur deformity which shows an oblique plane deformity of 45 degrees. This is the planning done for to correct the femur deformity. The site of osteotomy and degree of osteotomy were determined during pre-op planning. Plan was intermedullary interlocking nailing with known as a shish kebab procedure. This is a post-op X-ray of the patient after correction of femoral deformity. This is the right tibia, which also had a procavatum deformity, which was again corrected by intermedullary interlocking nails. This is a post-op 6-month follow-up X-ray of all the deformities. This is a video of the patient able to walk on his own after the combination of the 4 procedures. This is the improvement in the range of movement of the patient. This is the patient able to drive a 2-wheeler on his own after the surgeries. Thank you, sir.
So good morning everyone. Myself Dr. Mayank Singh, a second year PG resident. I am here to present the outcome of the deformity correction in tibia with Elizaro setup. So there is a brief introduction in which is a from technical standpoint, deformation is a change in which relative position of the point of solid body, the distance between which changes under the influence of the external forces. So in orthopedic surgery, the concept of deformation implies an disciplinary of reference lines and angles from the accepted normal values in the presence or absence of the shortening. The components of the deformation includes displacement along the length, angular displacement, peripheral displacement, and rotational displacement. The management of post-operative deformities of the tibia, either occurring immediately after the failed primary fracture, treatment leading to the malunion, or developing gradually caused by the injury of the growth mechanism, is continuing challenge facing the orthopedic surgeons. The external fixators for the management of tibial post-traumatic deformities have become a standard procedure over the recent decades. Better understanding of the reaction of the bone and the soft tissue to the gradual dissection has resulted in reduction of the historically high complication rate and improve the functional outcomes. So the aim of the study was to analyze the accuracy of the correction, the complication rate, and the clinical outcome, including the duration of the treatment. So the study design was taken. It was like prospective study. The time frame was from December 2022 to like 2024 Feb. It was done in OPD and casualty patients like in our college. The sample size was 24, in which the males to female ratio is as shown the sex distribution. 21 males were there and 3 females were there. Mostly the patients were of 31 to 40, between the 31 to 40 years of age. So these are the causes which the patient presents. Mostly the patient came with the RTA, 2 of the gunshot injury, and further osteomyelitis cases were 6, and 1 of the poliomyelitis. So we found that after applying the Elizaro, the complications, mostly it was a pin tract infection, which you can see here. The follow-up period ranged from the 10 to 36 months. The Elizaro frame was removed at mean of 16 weeks. The magnitude of the overall achieved correction ranged from the 11 degree to 25 degree. Excellent or the functional good results were present in 90% of the cases. So this was the first case in which the patient was 60 years old. He presented just 1 year after the trauma. When the patient came in OPD, found that the plate was in situ, and patient presented with the presenting sinus over there. So we planned an Elizaro for that to correct the deformity. So these were the X-rays, just post-op. This one is after the removal of Elizaro. As you can compare it, the sinus was totally almost like we achieved the infection control, and patient was able to mobile. This is the next patient which came, who came after 1.5 years of the deformity. He took treatment with like somewhere with a quake where he was applied a slab. Then he presented with the deformity and limping, and the sinus present over there, as you can see, and also there were recurvatum. So we planned for the Elizaro, in which gradually the deformity was corrected. And the final outcome, as you can see in this X-ray, patient was able to bear awake and walk, and the deformity was corrected with the help of Elizaro gradually. These were the post-op X-rays just after removal, and we have applied a slab for 6 weeks and was allowed mobile. So with conclusion, Elizaro is an accurate and reliable technique for the correction of the tibial deformity in adults. It is an important option in cases with severe deformity where the correction of more than 15 degrees was achieved in complex deformities in more than one plane. Thank you.
Discussing a topic on the tibial deformity corrections which we are done by Elizaro method. First of all, why Elizaro method? Maybe we can say that it's a good apparatus because it allows us to correct the deformities in multiple planes, allowing the good restoration of length and deformity. Along with it, because of the multiplanar fixation, we can allow the patient to wet bear early. Also, it provides us a new bone formation and excellent soft tissue management. So, first of all, we should always know about the normal anatomy and the normal varus and posterior slope of the tibias. And reference point, we take it mostly as the contralateral or the normal limb. And for the pre-op planning, we will mainly take the anteroposterior and the lateral X-rays. And we will be following the principles of the distraction osteogenesis. So initially, we divided into 3 phases. After surgery, first initial latency phase, which is a period of around 1 week to 10 days, where we will not attempt any distraction. And followed by which we will start by a slowly gradually distraction phase, which will be around 1 mm per day in 4 divided increments. And ultimately it will be a consolidation phase where we will start the patient to wet bear, and subsequently we will follow up with the X-rays. So this is a case series where we took 13 cases. There were mainly varus deformity of 12 cases, and one patient had a valgus deformity of around 22 degrees. In all cases, we attempted to achieve a medial medial tibial angle of 90 degrees. We included all the cases which underwent a percutaneous osteotomy and distraction, and which were corrected gradually. We didn't include any lax union or infective non-union because in these cases we have to correct the deformities very acutely, along with wedge osteotomy, which is also an acute correction. So, in the around the tibial varus cases, 6 cases were post-traumatic, out of which 4 were a malunion and 2 were stiff non-unions. 3 patients were skeletal dysplasia, 2 physeal injuries, and 1 patient was a severe osteoarthritis with genuvel. So, we had a complication. The patient developed a hypertrophic non-union, which we will discuss. In all cases, hinges were placed at the cora. Articular deformities in which osteotomies were done at the level of cora, but for the juxta-articular deformities, we did osteotomies at multiple levels. In all cases, fibular osteotomy was done, as invariably for correction of tibial deformity, we need a mobile fibula. Principles of distraction osteogenesis were followed. So this was the first case. This was a 20-year-old male who presented to us with a childhood physeal injury. The amount of correction was calculated to be around 32 degrees, which we attempted, and after 5 months of distraction, we were able to achieve the normal anatomy and length. This case was an 18-year-old child. Patient was a known case of achondroplasia, in which the deformity was calculated to be around 20 degrees, and following distraction, we could achieve a good alignment. This case is a 45-year-old female. She had a severe osteoarthritis of knee with genuvarum. This case, initially we tried distracting, but after 20 days we had to stop distraction because we were suspecting overcorrection of valgus deformity. And this case developed a hypertrophic non-union, which we'll discuss just now. So the patient developed a varus instability following the removal of fixator. Even after 1 year of follow-up, patient had pain on walking. So we suspected it could be a cause due to undercorrection of the deformity or maybe attenuation of the collaterals. So in the end, we managed it through a hinge total knee replacement with a tibial stem. So all patients, the mean tibial varus was around 24 degrees. We corrected all the deformities to around 90 degrees of medial proximal tibial angle. There were no skin issues or healing problems. We did a gradual distraction and no patient developed any neurological deficits. And subsequently, only one procedure, that was the removal of the fixator, was done. And one patient which had a tibial valgus of 20 degrees, initial shortening was around 8 centimeters, which we attempted, and we got a lengthening. So why we should correct the deformity acutely or chronically, or why we should do it as a single stage? There was a study done by Kawasa in which he studied 8 patients. In all 8 patients undergoing single level surgery and additional procedures, the results were nearly equal. Then why we should do it gradually and not acutely? Because there was a study done in which they studied 34 patients, in which in the end they concluded that if we do acute correction, there are more damage to the surrounding soft tissues, and also it provides more sudden gap between the bony fragments, which interferes with the callus formation. So in the end, Ilisaro fixator is a good tool to correct the tibial deformities. It also allows us early weight bearing and stabilization of bone. We should always keep in mind about the gradual correction and not do it acutely to prevent skin conditions. And also we should have a proper knowledge of the safe zones and anatomy to correct the deformities.
Good morning everyone. I'm Dr. Ratna Ishwar from Sri Balaji Medical College and Hospital. My guide is Dr. Vijay Narasimha Reddy and the co-guide is Dr. Subramani Gandhi. The topic for presentation for me today is the non-union of lateral condyle of humerus with cubitus valgus deformity treated with screw fixation. A 7-year-old female came to our OPD with complaints of deformity over a left elbow for the past 4 years. The history was given by a patient's mother and the reliability was fair. 4 years back, she had a history of slip and fall, for which she took native treatment in Puttur, which is a very famous institute for giving treatment down south. In 2019, the patient's mother noted a deformity and she wanted to know what was wrong, and she came to our OPD for further management. An X-ray was taken and she was diagnosed to have non-union of lateral condyle of humerus with cross valgus deformity, Mills type 2 fracture. This was the X-ray which was done. This is a plain X-ray of left elbow, AP and lateral view, which shows thickening in the lateral epicondyle, which is also irregular. Gross valgus deformity is also present. On local examination, the valgus deformity was present. 3 bony point relationship is altered, and lateral condyle is thickened and irregular. There was no obvious muscle wasting. Movements at the elbow joint, flexion, extension, pronation, supination were all full and free, and there was no distal neurovascular deficit. When compared to the normal side, the carrying angle was increased. The normal carrying angle is 5 to 15 degrees in a female, and in a male is about 10 degrees. Here in the right elbow it's 18 degrees, whereas the left elbow, where a native splinting is done, is 55 degrees. A Bowman angle is also calculated. What is the Bowman's angle? It is also known as the humeral capital angle used for assessing the supracondylar fractures. The normal value ranges from 61 to 80 degree, and anything greater than that is concerning for fracture with displacement. It should be compared with the other side, that is a non-injured side. Usually any Bowman's angle above 80 degree concerned with fracture, but we should also take into account the opposite side such that if there's difference of more than 5 degree, it suggests a coronal plane deformity. If we see here, on the right side it is 71 degree, whereas on the left side, which is the abnormal side, just 37 degrees. So there's a gross difference of around 35 to 40 degrees. So an operative procedure was decided, and the patient was treated surgically by non-union side debridement. The bone ends were freshened, the condyle fragment was opposed in position, and bone grafting was done. And we fixed the fracture with 2 cannulated cancellous screws. This was the immediate post-op X-rays, which was done with 2 CC screws. We followed up for the patient for a period of up to 1 year, where you can see obviously the carrying angle is being maintained, and we suggested the patient to come for implant exit around 8 months, such that the carrying angle at that time was 20 to 25 degree, but the patient was lost to follow-up, and she turned up to our OPD only 15 months later, and the carrying angle was increased to 30 degrees. So we had no other go but to plan for implant exit. So at 15 months she came to our OPD. This was the X-ray which was taken post-operative to the implant exit. the movements of the patient. If you see the cubitus valgus deformity has persisted as she came a bit late. The internal rotation is also, when compared to the right side, which is normal side, left side is slightly restricted, and supination is. Wait this moment. Yeah, supination and pronation is also full and free. Flexion is also a bit maintained. So, what are the causes of non-union of lateral condyle fracture? Non-union in lateral condyle is considered when there is no evidence of healing at 12 weeks. It mainly occurs due to pull of extensor musculature, inadequate stabilization or fixation, failure to recognize the fracture, any intra-articular fluid penetration into the fracture site, and any minor blood supply of fracture fragment because of vessels penetrating the metaphysis. Insufficient immobilization and fracture relocation. We suggested to patient to wait till 18 years or 21 years till the bone growth can be attained, such that there is a time for correction later. Suppose if the valgus deformity is maintained and increases, we suggested for corrective osteotomy, but the patient is yet to turn up in our OPD. Mayo elbow performance score was taken, and the criteria is based on 4 factors mainly: the pain, range of movements, stability, and daily activities. Our patient had a score of above 90, which proves an excellent outcome. These are the papers which supports treatment which we done in our college. Screw fixation for lateral condyle humerus, and this is another article. Thank you very much.
I will be talking on functional outcome of high tibial osteotomy in patients with medial compartment osteoarthritis knee using a dynamic axial fixator. So what is the purpose of a high tibial osteotomy? It is to redistribute the weight bearing forces from the affected medial compartment to the lateral compartment to relieve the pain and to slow down the progression of the disease. What are the techniques which can be used? It's a medial open wedge osteotomy, lateral closing wedge, dome osteotomy, or a hemicallostasis with the help of an external fixator. So what was the aim of my study? So the aim of my study was the functional outcome of high tibial osteotomy using a dynamic axial fixator and correlation of functional scores with the hip knee ankle angle. This study was conducted in a tertiary care hospital between 2016 and 19. 32 patients were included, that is 32 knees, but 2 were lost to follow-up, so we had a sample size of 30 patients, 30 knees. Patients with isolated medial compartment osteoarthritis with an age less than 65, with an varus deformity of less than 25, flexion of more than 90, of at least 90, a fixed flexion deformity of less than 15 degrees and without ligamentous instability were included in the study. Bicompartmental and tricompartmental osteoarthritis, lateral tibial subluxation more than 1 cm, flexure contraction more than 15 degrees, flexion, knee flexion less than 90 degrees, inflammatory arthritis, diabetes, obesity, and loss to follow-up were excluded from the study. So in the pre-op planning, AP view standing lateral views of both the knees were taken. Varus valgus chest views was also taken, both static for the differentiation between the static and the dynamic deformity. Bilateral lower limb scanogram was done. MRI to assess the status of the patella, meniscus, ligamentous lesions and cartilage damage. Pre-operative and post-operative function was assessed using WOMAC score, WHO score, IKDC and Oxford knee score. The Horos DICOM viewer software was used for planning. The mini ACI method was used for the calculation of the angle of the correction which is required. Hip knee ankle angle was drawn between the mechanical axis of the femur and the tibia on the medial aspect of the knee. The LDFA, MPTA, JLC was also calculated. This is the way we did our calculation. Surgical procedure, first a guide wire was placed in AP view 2 cm below the joint line aiming for the fibula tip. On the lateral view, we made sure that it was near the posterior cortex. Then over that we drilled using a cannulated drill, and then we placed our first shank screw. The second shank screw was parallel to the first one, and the distal shank screw perpendicular to the surface of the tibia. The line of osteotomy was done through a tunnel cam. There is a cam in the dynamic fixator. Through that only we passed a wire, and along that the osteotomy was done. This is the 3D saw bone model showing where the osteotomy was done on the AP as well as lateral view. So applying the CD unit, angular distraction of the osteotomy site was done with the help of moving the bolt of the CD unit till a Barrett's correction. So intraoperatively we did a correction tentatively, but we made sure that the hinges did not, the lateral hinge did not break. Distraction of the, and after once the correction was achieved with the help of the CD unit, then we again compressed the distracted osteotomy site was closed. 2 mm of compression was done at the osteotomy site, and the central bolt was tightened so that further movement was not. Then post-operatively, IV antibiotics for 2 days, bedside knee mobilization, touchdown weight bearing walking, that is non-weight bearing, but the foot is completely touched down. Distraction was start on 8th day, 0.25 millimeters 4 times a day, daily pin side dressing with normal saline, and regenerate fully consolidated after 3 months, and removal of fixation was done in OPD itself. So the results: 30 patients, 21 females, 9 males, mean age of 47, plus minus 8 years, mean follow-up 35 months, nearly 3 years. Mean pre-op HKA was 172, post-op HKA was 184. Goals was achieved in 24 out of 30 patients. These are the pre-op and post-op HKA, LDFA, MPTA, HKA, JLC and MAD. And these are the scoring. This shows a marked improvement in the pain scores and the knee scoring. The mean pre-op flexion was 125 and post-op was 128. A limitation of movement in 2 knees was there, which after some while it improved with physiotherapy. This is the pre-op X-ray on the left side, and the right side shows the post-correction X-ray. And these are the clinical images. Complications: 3 patients were had pin site infections, 1 had deep infection, and 1 had early consolidation, which required reosteotomy. No loss in bone stock. There was minimal invasive surgery, and no retained hardware, and so these are the advantages. Whereas the disadvantage is the pin track infection and fixation was around for 3 months, and so the chance of collapse is there. And the limitation of the study is a small sample size and a short follow-up. So conclusion: improve pain, function, activity of daily living and quality of life. HKA angle, an important parameter to restore for the better functional outcome. The main advantage of using dynamic axial fixator is the precision in achieving calculated correction without any implant in the bone once the correction is achieved with good healing rates. Thank you.
Only unique compartment, because osteoarthritis is, it may be predominantly one, but usually 5 compartmental or 3 compartmental you have excluded. How? What?
So we did MRI in all the pre-op cases. That way
MRI is not a foolproof.
Yes, but we actually had to, we wanted to assess.
You tell what are your criteria, right?
Yes, sir. So we basically, sir, we did MRI in all the cases so that we assess the lateral compartment, because if the lateral compartment is damaged, then there is no point in shifting the weight bearing line from the medial to the lateral side. And
which type of MRI do you do? That there is cartilage. So cartilage mapping do you do regularly?
no, ma'am. So we just, depending on the thickness.
That's so clinical criteria that's established. That's needed to look at that. If there is stable, the osteophytes are there. Does not mean that significant osteoarthritis is there. So if there is tenderness around the lateral compartment, that's the okay.
But
that's the
yes, sir.
from the expert.
Yes, sir.
doing HK angle 184 point something in
Yes.
every case, or some difference in age per age or active delivery?
So it depends. Actually, we have a try to keep it between 183 and 186. So it depends on the amount of damage on the medial side we sort of decide which side.
So, in every case, do you check the preoperative laxity with the stress view so that you can?
Yes. So, sir, if there is laxity, then
Do you check regularly with the stress
yes,
view?
yes.
That's the good practice. And have you come across anywhere? You have that usually many times there is also femoral deformity that is. So, have you come across that and how do you tackle it ever?
So, in this study, we generally go for overcorrection of the MPTA. That is the tibial correction. We do overcorrection till the MPTA till normal is till 90. We go till 95.
That's a separate issue. So, the issue is once there is femoral component.
Yes.
So, in that case, what's your that's it. Okay, that's true. And what is your desired angle? Because then you know the 2 mm, 3 mm, 4 mm, there are now algorithm. Do you follow it or not?
No.
Okay. So next time you do it. Okay. Thank you.
Thank you, sir.
Good step.
Myself, Ravi, I'm working as a senior resident at Solapur Civil Hospital. I'm presenting a case operated by my head of unit, Dr. Gurunath Bache sir, 19 years back. It's a case of congenital pseudoarthrosis tibia in a 6-year-old boy treated with the Ilizaro external fixator, and we have a recent follow-up after 19 years. So, what are the peculiarities of CPT? Main is it's challenging and misunderstood in pediatric orthopedics. The difficulty in treatment lies in a weak healing power, a chance of refracture, and osteoporotic bone. Whenever we achieve union, it is difficult to maintain that union, and the end result is frustrated child and the family who have been through multiple failed surgeries and remain with a short limb, deformed limb, and which is almost functionless. So this is the food. Why this? The clinical features: it's deformity, no frank mobility, patients walking with deformity and ankle in valgus. There are a few classifications. In Boyd's type 1, there's tibial defect. In type 2, pseudoarthrosis. In type 3, we got R-class constriction. In type 4, there is a pseudoarthrosis and sclerotic fragments. There is another classification, the Anderson's classifications, which is dysplastic, cystic, late, clubfold type, and anterior angulation type. In Paley's classification, we got type 1, which is atrophic bone ends, mobile pseudoarthrosis without any surgeries. Type 2, atrophic bone ends, mobile pseudoarthrosis with unsuccessful surgery, and type 3 is a stiff pseudoarthrosis. Now, what are the associated problems we faced? As limb length discrepancy, tibial angular deformity, proximal migration of fibula, valgus, ankle, and foot deformity. These are the pre-op clinical photographs. In our X-rays, severe angular deformity, Boyd's and Pellis type 3 pseudoarthrosis of tibia and fibula. The principle of treatment: many recent advances in treatment. Resection of hematomous tissue, periosteal sleeve grafting. We can do ring fixator with IM nailing, and cross union method with intermediary nail. So we operated, my HOU operated this case in 2001. So at that time, this much options were not available. So he chose to excise the CPT segment and do acute docking, proximal corticotomy, and almost there is 8 to 10 centimeter of bone gap, and then application of Ilizaro fixator with foot frame. Problems in this case were severe deformity, shortening, problems of acute docking and skin condition problems. Now, what are the important steps? Skin incision, which is S-shaped, excision of large CPT segments, subperiosteal dissection, excision of fibula segment, acute docking with temporary long K wires to maintain alignment, and Elizarov with proximal corticotomy in same stage. Fixator time was 18 months almost, and hospitalization duration was 10 weeks. Distraction rate was 1 mm per day, and pin track care. These are the immediate post-op X-rays. Elizarov fixator applied, CPT segment removed, and corticotomy done at a proximal level. These are follow-up X-rays while distraction is in progress. We are getting good region rate. With slight procurvatum of the proximal fragment is there. GAL is at pseudoarthrosis site, but there is no translation at pseudoarthrosis site. These are follow-up X-rays with complete region rate. These are clinical photographs. This is a X-ray just before fixator removal. This is a pseudoarthrosis site united. Then after fixator removal, we gave AK walking slab, and patient was walking with slab. This is a photograph of X-ray of X-ray after fixator removal. This is 1 year. Still procurvatum at corticotomy site is there. This is a final photograph, shortening almost 1 inch. These are few clinical photographs post-operatively. Small foot size, shortening almost 3 cm, and knee flexion is up to 90 degree only. We got a recent photograph, and after 19 years, and there are no refracture, and patient is walking happily. This is clinical images. He's walking fine, and there is no complication pre-fracture. And thank you.
What is the message you want to give?
Sir, we should keep long follow-ups and with the patients.
Two.
And
Just
second, with the limited armamentary, you can use any day use Elizarov fixator in children above 4 years.
If you are to operate right now, what different approach will you follow, or do you recommend?
Bone morphogenic proteins and
No, not that. These are not of yes. Anything more else? What essential surgical step difference? Most of it. Drawer pellet
removal
now.
of hematoma and applying a fixator is a
Drawer pellet tells that I treat every patient with 100% guarantee. Are you familiar with that? You have already mentioned. So one thing not to is the cross union. Okay, cross union with the fibula with the tibia. Large surface area make the both surface off and put extensive bone graft so that cross union across both the tibia and fibula vital area, so that there is chance of failure, refracture is less and union is more, and excision of thought. Okay, this is the essential. Third, if you have the expandable net, that's good. Thank you. You're a nice job.
I'm Dr. Pratyush, currently postgraduate in SIMS Hospital, Karnataka. Under the guidance of Dr. Shivanna, I have a case report on flexion contracture of hand managed with the Elizarov principle. So, coming to cause of wrist contracture, wrist and forearm contracture, the Workman ischemic contracture, where definition is, it is characterized by ischemic necrosis of the structure contained within the volar compartment of forearm, associated with crippling contracture and varying degree of neurological deficit. and it is a sequelae of inadequately or untreated compartment syndrome. So coming to etiology, there is crush injuries, prolonged external compression by tight bandages like tight cast, then internal bleeding which raises the intraosseous pressure, then it causes burn, snake bite, intravenous regional anesthesia, and trauma like supracondylar humerus fracture in case of children, and distal and radius in case of adult. So coming to explanation, there is acute ischemia leading to contracture and necrosis of the flexor muscles of forearm, especially the flexor digitorum profundus and flexor pollicis longus. Severe cases, all flexors and extensors are involved. So the muscle tissue is replaced by collagen that causes the contracture, and there is nerve injury also, which leads to dysfunction and sensory loss and leads to chronic pain. So there are deformities in areas of median and ulnar nerve distribution. There is flexion at interphalangeal joint, extension at metacarpophalangeal joint, thumb flexion and adduction, flexion at wrist, pronation of forearm, flexion at elbow, and neuropathy in median and ulnar nerve distribution. So these are the tolerance of the tissue. Muscle, there is functional impairment after 2 to 4 hours of ischemia, then irreversible functional loss after 4 to 12 hours, and in nerves there is 30 minutes and irreversible functional loss after 12 to 24 hours. So this is the classification given by Schultz, wherein mild type there is involvement of flexor digitorum profundus and flexion contracture of one or more fingers which can be extended on hyperflexing the wrist. There is resistant pronation and involving either the pronated teres or pronated protratus. In moderate type, there is involvement of flexor digitorum profundus, flexor digitorum longus, and part of flexor digitorum superficialis. There is neurological deficit involving median nerve. More than ulnar nerve is present. Deformity is intrinsic minus hand, and there is diminished sensation in median and ulnar nerve zones. In severe type, all flexors are involved. There is marked neurological deficit, joint contracture and wasting of forearm muscles. So the symptoms are pallor, pulselessness, pain, paresthesia, and paralysis of flexor muscles of forearm. There is one Volkmann sign when extension of the wrist causes exaggeration of deformity, while flexion causes the deformity to be less marked. So coming to the technique of Elizarov, Dr. Elizarov contributed to the study of this principle where the technique focuses on distraction osteohistogenesis for limb reconstruction. Elizarov technique operates on the principle of distraction, wherein controlled mechanical stress induces bone and soft tissue regeneration, facilitating gradual limb lengthening and correction of deformities. So this is one case which presented to our hospital. So he's a 7-year-old boy with right hand dominant, and he had a green stick both bone forearm fracture. So on initial presentation, we had applied a slab and was advised to follow up, but patient denied and he went to traditional practitioner where they applied tight bamboo sticks, which was too tight, and it went into compartment syndrome, but it was late. So again they went to hospital where they did the fasciotomy. So this is the video which he presented to our hospital after deformity. And we applied Elizarov frame with rubber band slings on fingers which acted as a dynamic splint mechanism. And this after the removal of Elizarov frame. So this is the result which we got after removal of frame. There is a slight restriction at the wrist joint in extension, and the patient is also able to open the cap of bottle, which denies that it is there is good grip strength in the patient hand. So in 1.5-year follow-up, there was a satisfactory functional outcome, and the quick test score was from 38.6% in initial presentation to 6.8. The range of motion of wrist, fingers and thumbs as well as skin sensation was improved and approximately equivalent to the normal left hand side at that moment. So this is the result before treatment and after treatment. Thank you, sir.
Old thoughts. In child, how do you know that there is vascular ischemia?
Sir, failure will be there.
3A now. And another 6. Increased demand of another 6. Anxiety. Okay? 3 years. Now, can you explain how do you distract it with the frame?
Sir, there was a gradual slow distraction.
No, but the placement of wires and rings.
As a hinge was placed at the hand.
So go back to the clinical picture with the frame. And when do we do the present late? When to do the episiotomy and when not to do the episiotomy? Is there any clear-cut guideline? Do you know? Okay. Just ensure that clinical picture you can. Okay. Thank you.
Opportunity. My topic of talk is early outcome of osteotomies around knee for knee preservation. So as we all know that knee osteoarthritis is a progressive degenerative disease characterized by gradual loss of cartilage primarily due to metaphyseal varus. In cases of severe varus deformity in knee, it is attributed not only to bony deformity but to articular deformity as well. That is because of the medial tibial depression, what we call powder deformity, or because of instability. This leads to mechanical axis deviation and also affects load-bearing forces of medial lateral joint compartments and increases the pressure led by the cartilage and the underlying subchondral bones. Osteotomy around knee helps to rebalance the force between the medial and lateral compartments, and it reduces the pressure borne by the cartilage and subchondral bone. Osteotomy has the advantage that it retains the anatomical structure of the joint and preserves proprioception and greatly delays the progression of osteoarthritis. Osteotomies around knee thus better suit surgery for young and active high-demand patients. So with this background, we aim to evaluate the outcome of periarticular osteotomies around knee for knee preservation cases with monocompartmental osteoarthritis due to malalignment with or without ligamental laxity. So our inclusion criteria include a physiological age up to 65 years, a BMI less than 30, physiologically active patients, range of motion 10 to 90 degree, and correction required less than 20, and with non or mild to moderate patellofemoral osteoarthritis. We excluded the cases with rheumatoid arthritis and severe patellofemoral osteoarthritis. Instead of choosing a single osteotomy for all cases, we customized the osteotomy as per the need, and our workup included the malalignment test to decide whether femoral or tibial osteotomy is needed, and identify the level of CORA, we chose type of deformity as per the case, and determine the magnitude correction and choose type of fixation. Our post-op rehab included endopost walk and knee range of motion immediately next second post-op day, and partial bed-feeding walk and full bed-feeding walk 6 weeks onwards. Ex-fixator, in cases where we use external fixator, it was removed after clinical radiological union. Our study included 28 knees of 24 patients, right side more common in front than the left. Range of age is 18 to 69 years with average of 51.7, and duration of symptoms was 25.1 months. Our indication for surgery was primary osteoarthritis with Varum in 11 cases, primary osteoarthritis with instability in 10 cases, with anti-instability in 2 cases, and malnutrition tibia with LC laxity in 3, and with LC and PLC laxity in 2 patients. We chose external fixation method in 12 and internal fixation in 16 patients. In every case, we did diagnostic arthroscopy, but we did not do any root repair and any ACL reconstruction. Synovial debridement was done in all patients who underwent arthroscopy, and we used bone graft substitute in only 3 patients. Average time of radiological union was 11.58 weeks. We had complication also in few patients, serious discharge 3 patients. In those patients in which we use bone graft substitute. Under correction 2 patients, swelling in 3 patients, and pin tract infection 3 which healed with conservative treatment. A few examples of 50 years female with bilateral gene vera with OE and malalignment test showed deformity primarily in the tibia. We chose orthofix fixator for correction, and this is the deformity corrected at around 15-16 days. We kept the fixator for 2.5 months and removed. The same fixator is applied on the underside, side, and this is the final correction, and this is the 6 months clinical radiological evidence of the patient. Patient is walking comfortably. Patient was earlier having symptoms for 3 years, was not able to walk properly. And the patient with the 56 years male with malnutrited proximal tibia with instability. Patient had malnutrited tibia fracture with anti-instability, and malalignment test showed oblique plane deformity, and which we corrected by the fixed fixator. And this is the final correction, and patient is able to walk very well. And the patient with the 55 years female with left knee pain, malalignment test showed primary tibia vera, but we found a lot of instability, so we chose intra-articular did TCV on this patient, and this is the final correction with good alignment. And this is patient can go at 4 months post-op, patient is walking comfortably. And the patient with 40 years male bilateral gene vera, having symptoms for 3 years, and this patient was hardly able to walk for a few meters. So malalignment test showed deformity of both femur in tibia right side and tibia left side. So we did correction by orthofix on the left side. This is the final correction, and we did double label osteotomy for the right side. This is the final alignment, and this is 2-month post-op photographs. Patient is doing pretty well, and he is able to walk now comfortably at 2 months post-op. So about the osteotomy around the knees, H2 is believed to treat varus alignment of the knees with medial medial situation, leading to medial compartment overload. In cases of varus deformity with abnormal LDFA and MPTA, we recommend combined H2 and DFO, distal femoral osteotomy. And with the patient with instability, we recommend tibial condyle valgus osteotomy. However, in cases with abnormal large varus MPTA with instability, focal dome condyle osteotomy is to be done. But what is required is meticulous planning, and all possible armamentarium has to be available to avoid poor surprises. So, take home message is osteotomy around knee is an easy surgical procedure with low risk, and almost all cases obtain rapid recovery, delays, and avoid arthroplasty. Meticulous planning is required, and correction to be done at CORA, and alignment is of primary importance. Thank you.
Internal rotation of the tibia. In your second case, in the post-op patient, patient has still some internal rotation. Patient is working with some intoing, I think.
That is because patient was having this complaint for 4 years, so it's too early because we have to rehab him also because he is having deformity. He had fracture at hip also and knee also, malalignment tibia. So we have asked him. It's a bit of around 5 degrees of internal rotation, but with gait training he will probably improve better.
Do you take care of that internal rotation?
Yes, we take care while doing intra-articular action. It's corrected automatically when you do osteotomy in case of TCVO, and when you distract it automatically goes in external rotation by its property, and that also balances the knee also. It increases the tensile strength of the ACL also, and corrects the internal rotation also. TCVO.
Do you overcorrect in old people? Do you overcorrect a bit?
In which patients?
In Genovera patient with osteoarthritis.
With patient, if young patients, we try to keep it to the MAD 50 to 55, and elderly patient, when we are doing this TCVO, we are not bothered about that how much it is going, but the aim is to keep this lateral triple plateau parallel to the tangent over the convex or lateral condyle most convex point. So that is the aim. But in elderly patient, we try to keep it more on the later side as compared to the young patients.
Last case appears to be, if I'm not wrong, last case appears to be a little more vulgar.
It was because, but we have to do it because to correct the instability. Because patient, I could not, because of the constraint time, I cannot show the clinical. It was so unstable knee. It was all in anterior, posterior, and the middle lateral. And if you would have noticed, I had done fibular osteotomy for casual correction of the lateral subluxation of the knee and the tightening of the lateral structures also. So we have given the hinge knee brace also for some time, for 2 months. So that, and it helps a lot. In both sides we have done fibular osteotomy, and that corrected the instability also and the lateral subluxation.
Thank you, sir.
With the knee instabilities, anterior instabilities, have you changed the slope or anything? What's your thought that could have been with the ring that could have been both the...
Yes, slope has to be changed, but because this patient had overall instability, and because the central posterior instability were same on the both sides, we thought it's because of the ligament laxity. We did not. But if you see that case, second case in which we did by that fix, we changed the slope because patient was having lots of high table slope. We changed the slope also. We reduce the slope in that patients. So we do that. And we can do by the plating also. By doing the STO, by plating we can change the slope.
Do you purposefully pre-planned way external rotate it in every case, or will it stand as well as some posterior?
Sir,
do you follow it or not?
Yes, we follow. We are not holding it to internal rotation. Okay. Whatever where it is going, we keep that.
Good morning everyone. The topic I'll be presenting today is a case of complex deformity of knee corrected using Ilizaro fixation in a teenage patient. The presenting complains with a 17-year-old male presented with a forward bending deformity of the knee, which was progressive over the last 2 years. The patient was not able to weight bear and walk using the affected limb due to the deformity. History of presenting illness. Patient was apparently normal 4 years back when he developed pain and limping over his left knee. He went to a nearby hospital and was treated conservatively. After 2 years, patient had a slip and fall at home and injured his left knee. Since then, he had pain and noticed the swelling in his left knee. After which he went for native splinting, 1 episode of massaging followed by 8 splints over 80 days from the proximal thigh to the ankle. During each splint change, manipulation and massaging was done and the patient gradually noticed a deformity in the knee after 3 to 4 splints, which was slowly progressive over 2 years of time. During the course of treatment, patient developed loss of weight, appetite, cough, evening rise of temperature, for which he went to a nearby hospital and was diagnosed to have pulmonary tuberculosis and was started on anti-tubercular drugs. During the treatment of pulmonary tuberculosis, patient noticed a swelling in his left knee, for which knee aspiration was done. The synovial fluid analysis, which was sent for analysis, showed an elevated adenosine deaminase levels, a total counts of 400 cells, which was also elevated, and increased glucose and protein levels. The acid fast stain showed positive, which was indicative of tuberculosis. The anti-tubercular drugs course was continued for 9 months and was stopped. Patient then went to a private practitioner for further management of the knee flexion deformity and was planned for lower tibial pin traction. During the lower tibial pin traction, the patient complained of paresthesia of the left foot and so it was removed. Then he came to us for further management. Local examination. The patient in supine position with a hip in 45-degree flexion and the knee with more than 90 degrees of flexion. The borders of the left patella were not appreciable. There was obvious thigh and calf muscle wasting. The left knee had a 90 degrees of flexion deformity. There was hamstring tightness was present, no palpable popliteal swelling. The patella was fused over the femoral trochlear groove and the borders were not clearly defined. Synovial thickening could not be appreciated. The movements. The patient had 90 to 100 degrees of painful flexion over the left knee, and further flexion was not possible. The hip flexion and hip extension were normal, and knee extension could not be assessed. Measurements. There was no obvious limb length discrepancies was noted. Thigh and calf muscle wasting were present. Left hip and ankle joints were clinically normal, and right lower limb and spine were also found to be normal. This is the pre-op X-ray. Compared to the right side, the left side shows erosion of the articular cartilage and fusion of the patella over the femoral trochlear groove and a flexion deformity of the knee. The CT scanogram was done to assess to calculate the flexion deformity and was found to have a flexion deformity of 90 degrees. This is a diagrammatic representation of the femoral and tibial angular deformities with joint laxity compensation measurements. These measurements showed us that in our case there was more of a soft tissue deformity than a bony deformity, which did not require a bony correction. So we did only a soft tissue correction using Elizaro. This is a CT3 reconstruction showing eroded joint cartilage and flexion deformity with subchondral defects. MRI of the left knee showed a diffuse marked irregular synovial thickening involving the entire knee joint. A large subchondral erosions noted involving the articular surface of the tibial and femoral condyle and patellar facets. Erosions along the medial tibial condyle and fibular head extending across the physis into the proximal metaphysis. Marked intramuscular edema. Complex destruction of the medial and lateral meniscus and ACL. The PCL and collaterals were intact. The diagnosis we made was fibrous ankylosis of the left knee with fixed flexion deformity due to post-TB sequelae. The patient was planned for a two-stage procedure. The first stage was common peroneal release with the deformity correction of the left knee using Elizaro fixation. The second stage that was planned was arthrodesis with Elizaro fixation. The preoperative planning was done using the rule of thumbs, in which the olive wires were placed at the ends of either bone and at the fulcrum points on the opposing end of the deformity's peak. This is the preoperative preoperative planning was done, and the frame was mounted on the patient's leg. The operative notes, initially the common peroneal nerve was released and all the bands around were released, and the distal femur, proximal frame of the proximal frame of the leg and the distal frame of the leg were all fixed using Schanz pins. The reduction was checked and found to be satisfactory. The skin marking for the fibula head and the common peroneal nerve release. These are the intraoperative images. The immediate post-operative X-ray. The rule of similar triangles was used for the hinge placement, according to which this calculates the ratio between the distraction rate and the opening wedge in the tibial and the fibula convex. It usually, in the tibia and the fibula convex, there's an opening wedge of 1 mm with 4 mm of distraction per day. The deformity correction was slowly assessed, and this is deformity corrected from 90 to 70 degrees, from 70 to 40 degrees, and 40 to 26 degrees. And as we progressed with the distraction, we noticed a stress fracture at the distal femur pin site. The distraction was halted and serial radiographs were collected until the fracture site showed excellent signs of union. The distraction was continued until the tibia and femoral angles were at 5 degrees of flexion. This is immediate post-op X-ray. The patient was satisfied with the initial stage of treatment, which gave him a stable and a pain-free joint. So the patient did not want to proceed with the arthrodesis of joint immediately, as he was comfortable with his normal weight bearing, and he continued with his day-to-day activities, and is now the sole breadwinner of the family. After the deformity was corrected, we created the satisfactory gait and the patient was happy. The patient was advised regarding the possibility of developing early onset joint arthritis and joint instability, which may require knee arthrodesis at a later stage. The patient was also advised shoe heel raise to compensate for 1 cm shortening post deformity correction. The benefits of using Elizaro: it gives a 360-degree compression, it helps with rapid weight bearing, and at the initial post-operative stages, the fusion angle and the pressure might be modified if they are not optimum. And the installation of the Elizaro frame is far from the affected site of the knee joint, which limits the spread of tuberculosis. So Elizaro is the best alternative for treating deformity corrections.
Anybody, any questions?
100 degrees, a painful jog of movements. After that, it wasn't possible.
So you said this is more of the soft tissue deformity, but you also told MRI findings showed femoral medial tibal condyle damage. So why it is not intra-articular deformity? Because in cases of the femoral condyle deformity, if you do this malinterest in sagittal plane, this gives the idea. It shows normal PPTA and PDFA. So it is not soft tissue alone. It is also involving the bone.
It does involve the bone. Intra-articular.
So in that case, you would have corrected the bony deformity, and you would have this would have been a bit simpler rather than doing this complex thing. You did so much release, and you did afterwards you explained patient this for the arthrodesis.
Yes, sir. CPN release was done. The deformity is a severe deformity, is more than 90 degrees. So when you're distracting, there could be stretching of the nerve.
Doing it slow, or you are doing it in a single stage?
Slow.
Slow distraction.
Slow.
It's a histogenesis, so everything will be stretched out now, vessels and everything will be stretched out. I don't think CPN release is needed, number one. Number two, the stress fracture in the femur is because the application of the hinges were at the lateral side. They should be toward the anterior side, so your tibia doesn't jumble up to hit the femur. If you see the application of the hinges, that's why you have got a stress fracture over there.
Sure. Good question, Ranger. Could it have been done in one stage? Because there is erosion you are talking.
Yes, sir.
Okay. So there is negligible range of movement. And the X-ray shows it's not active tuberculosis, right?
Yes, it's not active, sir.
Because there is no such erosion. That could have been done. One thing, the only concern if there is neurovascular, but however cartilage. Have you distracted them before that while stretching out? While stretching out with the iliac vein, at the same time initially there should have been, have you arthrodiastasis have you attempted? Because without that you cannot really extend it further. Have you attempted that?
No, sir.
So in any case of contracture correction, first few days 4 or 5 millimeter distraction is needed so that you get the space. Okay. Thank you.